That should do it. That do it?
Yep, you're good.
I'm gonna turn off my camera for half a second, but I'll be right back. So I can, oh, it's not gonna let me do it. I'm here, just moving slightly. Great.
If you're logging in now, we're just waiting for folks to gather for our next webinar of the U.S. Deprescribing Research Network, and we'll get going in just a few minutes. So welcome, everybody. You have joined us at the webinar for the U.S. Deprescribing Research Network. We're just going to let one more minute go by so we can let people log in. So welcome, everyone. You've joined the U.S. Deprescribing Research Network webinar, and I am your host today, Dr. Jennifer Chia, along with Ken Bookvar. We are the co-leads of the Investigator Development Corps for USDEN. And we're really excited for this webinar today, which is about complex challenges in pain and opiate management and its relevance to deprescribing. This webinar is sponsored by the U.S. Deprescribing Research Network with funding from the National Institute on Aging. Before we get started, I need to just cover a few technical details. Due to the number of registrants for today's webinar, we have placed all of the audio lines on mute to reduce the audio feedback. So unless you're logged in as a host or panelist, your line is muted. However, we do welcome and encourage you to participate using the Q&A feature on the Zoom webinar software. When you'd like to interact with the presenter, please click on the Q&A bubble on the bottom of the toolbar and type your questions in the box. If you would also like your question to be anonymous, you can click the anonymous box before sending. Our host, Ken, will acknowledge the questions during the final 15 to 20 minutes of the webinar. And after the webinar, you'll receive an email with a short evaluation, so don't forget to fill that out. If you happen to experience any technical questions or logistical issues during the webinar, we ask that you submit those using the chat box and select a co-host, Jonathan Norton, to chat privately. We want to make sure that you're identified by name, either by name or participant ID. In that way, he'll be able to help troubleshoot. We also would like to extend a huge thanks to Gabrielle Schiller at Mount Sinai, Jonathan Norton at Hopkins, and Raha Shrafrudi and Haley Schiff at UCSF, who really do all the heavy lifting in the background to make all these webinars possible. And so without further ado, let me introduce you to Dr. Merlin. Dr. Jessica Merlin is professor with tenure in the Division of General Medicine and director of the Challenges in Managing and Preventing Pain, the CHAMPP Clinical Research Center at the University of Pittsburgh. She is a physician and board certified in internal medicine, infectious disease, palliative care, and addiction medicine. That's only 4 board certifications.
It's expensive.
It's expensive. And you have an MBA. So she's also a PhD trained behavioral scientist and NIH funded clinical investigator. Her program of research focuses on the intersection of chronic pain and opioid misuse use disorder across populations and settings, especially in individuals with serious illness like advanced cancer. So she is MPI of TREETOP, Tailored Retention and Engagement for Equitable Treatment of Opioid Use Disorder and Pain, and just has a bunch of funding and does all sorts of cool work I have lucky to know her through the Sojourn Scholars Leadership Award Program, meaning that she's a leader in opioid management and thought. That's sponsored by the Cambia Health Foundation. And she's also had many research awards, including from the American Academy of Hospice and Palliative Care, American Pain Society, and the Association of Multidisciplinary Education and Research in Substance Use and Addiction. That's a mouthful. So anyways, welcome, Dr. Merlin. We're really excited to have you present and talk to us about this super important topic.
Well, thank you for that very kind introduction and for inviting me here today. It's great to be with you all. And I have logged in on my phone as well as on my laptop so that I can just kind of keep an eye on the chat, although I know Ken is going to be also doing that. So if folks want to throw comments or questions in as we go along, please feel free to do that. I'm happy to make this interactive and informal. And, you know, I really just want to say before I start that I am not a deprescribing researcher. I am sort of an outsider to this group and very grateful for you all thinking that my work has relevance to this area. And so, you know, one of the things I've enjoyed most about being at the intersection of many fields, like Jennifer just mentioned, is that I find that oftentimes many fields are working on the same problem using different techniques and different approaches, and just bringing those things together can be incredibly powerful. And so I'm really looking forward to sharing my work with you here and just hearing your thoughts on how I'll tell you how I think this relates to deprescribing from my understanding of deprescribing, but I'm really also very eager to hear how you think this relates to deprescribing and think about ways we can all collaborate. So Jennifer already mentioned my Cambia conflict of interest there. And as Jennifer mentioned, really central to all the work that I do is this idea of complex challenges in pain and opioid management. And how I got there was that, you know, I'm infectious disease trained. So I started off trying to understand how to improve pain in people with HIV. And as part of that, in my K award, I got a PhD in health behavior and really got very interested in developing and testing behavioral interventions for chronic pain tailored to people with HIV. And so, and I have an R01 now to test the intervention we developed during my K, which is very exciting. But also through that work and through my clinical work in caring for people with HIV and chronic pain, you know, I saw a lot of patients who were being prescribed opioids who weren't doing that well, and got very interested in this idea of opioid misuse in primary care settings generally. So this idea of taking more opioids than prescribed, or using other substances at the same time as using opioids, or taking opioids for symptoms other than pain, like depression. And so have worked on developing consensus-based approaches to how to manage these types of behaviors in primary care settings. And that really led me to work on the intersection of pain and opioid misuse and opioid use disorder in primary care settings generally, and in office-based addiction treatment settings. So really focusing on the specific needs of patients who have both pain and opioid use disorder, and developing and testing behavioral interventions to improve both pain and opioid use disorder outcomes. And as Jennifer mentioned, I'm trained and boarded in palliative care, and kind of all of this came from my interest in pain and symptom management in people with HIV, which of course is a serious illness. And so I've also kind of tapped into my roots there by really expanding my work on pain and opioid misuse, opioid use disorder in individuals with serious illnesses more broadly, particularly patients with advanced cancer, and doing some of that same kind of consensus Delphi work that I mentioned that I do in primary care related to opioid misuse in the advanced cancer population. And then you can't really be a pain researcher without at least, you know, touching somewhere on cannabis. So my particular interest in cannabis has to do with decision-making at the point of sale, how people make decisions about what to buy and how they're counseled by people at dispensaries. So that sort of relates to the rest of this by virtue of the fact that, you know, I'm a pain researcher and it's related. So so that's kind of the full entirety of my work. And I just sort of put here that, you know, I've got some R grants, and I have an NIH center grant, particularly at the intersection of pain and opioid addiction, and a K-24 that's pending. Okay, So I'm going to actually, sorry, I'm going to focus today. I could focus on sort of deprescribing, actually, I think with almost any of these things, but I'm really going to focus most on deprescribing and with regards to opioid misuse in primary care, and then opioid misuse, opioid use disorder in people with advanced cancer. But before I get there, I have to acknowledge the work of some of my wonderful colleagues. So Dr. Amy Pickering, who I was her fellowship program director when she was a Gen Med fellow not long ago, and her mentor, Dr. Tom Radomski, and I think Amy is on this call. These folks really introduced me to the concept of deprescribing and have helped me kind of frame my work in as it relates to that. So just to kind of showcase a little bit of their work and how it did that. So Amy and Tom did the study, older patient and caregiver perspectives on medication value in deprescribing. And what they really found was that medication features that add value were perceived effectiveness, including subjective improvement in symptoms. And I'm going to actually skim through these quotes because I realize we're a little bit shorter on time than I realized, because I want to make sure we get to some Q&A. Objective improvement in clinical values, disease prevention, and then medication features that detract value, adverse effects on quality of life, including severity of side effects, inconvenience associated with administration, and discomfort associated with administration. So how these insights relate to opioid prescribing is basically, patient perception of symptom improvement. So, there is, in addition to the literature I just presented, there's also literature that suggests that people prioritize their pain more highly than other symptoms. And so I really think that addressing what matters most to patients is key. Also to kind of getting them linked in with care and adherent to care. Many formulations and medications are available to address the side effects. So, we have multiple approaches that we can use within the medications that are available. Opioids are fairly convenient and comfortable to administer as well. So now on to my work. So as a clinician, my work is very heavily motivated by what I see in clinic, as I said before. And so I'm just going to structure parts of my talk by kind of the clinical questions that prompted that body of work. So among patients with or without HIV in primary care prescribed opioids, what is the best way to manage opioid misuse behaviors? So as I already sort of alluded to earlier, opioids are commonly prescribed for chronic pain. Safe opioid prescribing requires careful attention to patient behavior. So really monitoring patients and understanding, what crops up along the way. Are they, taking more opioid than prescribed, taking opioids for symptoms other than pain? Are those things really kind of representative of compulsive use? Are they developing an opioid use disorder? These types of things are very common in clinical practice. So there's a systematic review from 2015 that I think still holds up well that suggests that about 25% of people have opioid misuse behaviors who are prescribed long-term opioid therapies. This is just a very common thing in primary care. It may signal a serious underlying opioid use disorder or not, right? So it might just be poor health literacy or numeracy. It might just be cognitive impairment. I don't want to say just, it might be cognitive impairment. It might be other things that are addressable, not necessarily opioid use disorder. And these things have an unclear course of action, right? So you can imagine that each of these behaviors has its own differential diagnosis and its own way that you might approach it. But you could also imagine that different people might approach this differently based on their expertise. And we do know that these behaviors, managing these behaviors in primary care can lead to dissatisfaction and burnout among clinicians. So, and in addition, as I'm sure everybody here is aware, the CDC in 2016 released guidelines on opioid prescribing for chronic pain, which have recently been updated. But this has really led to kind of increased scrutiny and increased focus on these types of behaviors in primary care settings with very limited evidence on how to respond when they arise. And I'll sort of tell you anecdotally that, I think when I started working in this space, it was 2016, 2017 or so. And at that point, people were really struggling with how do you respond when these behaviors arise? And so, of course, many years have elapsed since then. And I think, what we've seen is a lot of people have made the decision on their own to just taper patients like this, or cut them off, or refer them to another clinic, and sort of, not be the ones to be managing this, which I think is a response to what you do when there's very limited evidence on how to best manage people in this situation. But we know that that's kind of what's happened over the last few years. At any rate, so back in 2016, 2017, we did a study using the Delphi approach to try to understand what the best management strategies are for these individuals. And so I don't know how much you know about Delphi, but it was developed by Rand, and it's really used when there's a lack of evidence, but an urgent need for guidance. And it's really a systematic approach to explore whether consensus exists, and if it does, to identify what the consensus beliefs are among a diverse group of experts. And it's a widely accepted level of evidence that is used for a variety of things that can drive policy and practice, including guidelines. So our study was to conduct this Delphi process amongst participants recruited from expert groups who prescribed opioids, and are self-reported as experts, basically because they are either the point person for opioid prescribing in their primary care clinic, they are in primary care, but also are addiction specialists, those sorts of things, or they participate in various networks that do teaching related to opioid prescribing. So we had a way to identify primary care-based experts in this space. And we had 4 online rounds. In the first round, we asked people to brainstorm behaviors and pick the 2 most common and 2 most challenging behaviors from the behaviors that they brainstormed. And then we asked about management in the second round of the most important round 1 behaviors. And in round 3, we did the typical Delphi rating approach, where we asked people to rate the importance of round 2 strategies on a 1 to 9 scale. And we had some a priori rules about what would make for consensus and what would make for disagreement. And you can have consensus that an approach is a bad idea. You can have a consensus that an approach is a good idea. Or you can have consensus that you're uncertain about whether an approach is a good or bad idea. And then you can have outright disagreement, where you have a lot of people thinking that it's a bad idea and a lot of people thinking that's a good idea. So we had a priori sort of mathematical rules about what constituted these various categories. And we encouraged free text clarification so we could do some qualitative work. And so we developed some cases that participants could reflect on based on those most common and challenging behaviors. And we told participants that the consensus, this is in the 4th round, sorry, we developed these cases where we told participants, okay, we've already done the following things. And we took those approaches that we told people had already been done from what we determined was consensus in the prior categories. And we highlighted branch points in people's thinking based on the comments from the prior round. And if there was disagreement, we provided the prior round response and re-asked the question. So this 4th round was really meant to allow people to see how these consensus approaches might be used and to, potentially amend their prior responses, as well as further clarify some of these decision points. So we had a decent number of participants. So we had 42 participants in the first round, and by round 4, we were down to 28. Which for a Delphi study is okay. It's not the best, but it's good enough for us to be able to draw some conclusions from this. So mostly we had physicians, internists, a lot of academic primary and specialty care. We had a lot of VA representation, particularly because opioid prescribing is of keen interest to the VA, and there are a lot of internists within the VA who have developed a lot of expertise in this area. We had all US regions represented. So the 6 most frequently cited common and challenging behaviors that we found were missing appointments, taking opioids for symptoms other than pain, using more opioid than prescribed, asking for an increase in dose, and alcohol or other substance use. so common strategies that there was consensus for agreement on, so people agreed that these were good strategies, were not immediately stopping or tapering abruptly, to do some patient education, to determine if there's a pattern of behavior present and if there is an opioid use disorder. And if there's an opioid use disorder, you want to treat it. If there's a pattern but no opioid use disorder, you might still find that when you weigh the benefits versus risks, the benefits don't outweigh the risks, and you might still consider tapering or stopping the medication. So that's generally speaking what we found across behaviors. And there were obviously some differences, but I'm not going to get too far into that because I'm kind of wanting to sort of show you the big picture here. But I will sort of quickly go through a couple of the algorithms that we developed based on this. So based on these results, we kind of put the results into algorithms that clinicians could easily use. And with the algorithms, we did a little bit of additional piloting with some nurses who had expertise in helping manage opioids for primary care patients, and did some piloting with some PCPs. And so we were able to kind of fill out some of the aspects of the algorithms that just didn't come from the Delphi study. So for example, missing appointments with the clinician who's prescribing the opioid, it's not recommended to stop opioid therapy immediately. It is recommended, and this wasn't something that came out of the Delphi study, but is something that we provided as additional context, is figure out what's going on. So consider structural factors, and then determine if a pattern of behavior has been present. If it's the first time, you instruct the patient to reschedule. If it's the second time, provide a short prescription, only enough until the next appointment. And since you've already considered structural factors, you should know by that point whether this is primarily a transportation issue or some other structural barrier that's preventing the person from coming. You review the opioid treatment agreement with the patient. You require appointment attendance if opioids are to be continued. You give the patient one last chance. And then if they continue to miss appointments, then you would taper opioids or stop opioid therapy completely. And I will, just for the sake of time, just go over one other one, which is the substance use algorithm. And this is a good example of one that had a branching point. So this is other substance use, including cocaine, meth, benzodiazepines, and heroin. So heroin, people sort of felt was a special case. People felt that heroin use represented a substance use disorder more likely than not. And so really considering pharmacotherapy for opioid use disorder right away and stopping opioids immediately or tapering opioids as important sort of upfront strategies. But otherwise, people recommended discussing or assessing for substance use disorder, referring for addiction treatment or related services, reviewing the opioid treatment agreement, ordering urine drug testing, and determining if a pattern of behavior has been present. So this is a really key branch point. If there is a pattern of behavior present, but whether or not there is a substance use disorder, it's recommended to taper opioids. If there's no pattern of repeated use present and there's no substance use disorder, if you might still consider tapering opioids, but this is sort of a less strong recommendation than over here, where you would want to taper some of these opioids. Okay. So I'm going to skip this. Okay, so just to mention here that we had these algorithms. Now we have about 8 of them for each of these behaviors, and our next step is really to identify and operationalize implementation strategies for these algorithms, which, since they're based on Delphi results, we really consider them to be evidence informed. A sufficient level of evidence where we would feel comfortable doing a pilot and then a full-scale trial of implementation strategies for these algorithms. And so I have a funded R34 that's actually about to end. So we've gotten pretty far through this, where we identified implementation strategies for these algorithms. And the short story on that is EHR integration, training, e-consults for some of the more complicated things that these algorithms recommend. And then we've already started and are several months into a pilot trial of these implementation strategies. And what I will tell you, even since I made these slides a few months ago, has happened is that, you know, as I said before, you know, when I first, this is the life cycle of an NIH grant, right? So when we first did that Delphi study, and then when I wrote this R34, this was a super hot topic, and this was really, you know, when the rubber hits the road in primary care, people, you know, primary care clinicians were really focused on how to address these opioid misuse behaviors. And what happened, because there wasn't a lot of guidance on this, it seems, is that people did either taper or refer these patients to other clinicians. And so now the issue that we're running into is that there are very few patients who primary care clinicians can identify as having opioid misuse behaviors in primary care. And my sense is that, yeah, it's not that these individuals, you know, vaporized, it's that they are either, you know, either they have an opioid use disorder and they're getting opioids from non-medical sources, or they are being managed in a different care setting. So I think that in and of itself is probably an important finding of this study. And I also think that these algorithms could potentially be used in the care settings in which these patients are, which, you know, maybe pain clinics, maybe addiction clinics, we don't really know. But so yeah, I am just checking on the chat. I don't see any questions or comments yet. So I'm going to continue to keep an eye on that, but move on to the next study that I wanted to highlight, which is taking this into the serious illness space. So just to put us all on the same page. So when I talk about serious illness, I'm talking about a condition that carries a high risk of mortality and either negatively impacts a person's daily function or quality of life, or excessively strains their caregivers. And because it'll come up here and there in the discussion we're having, and I've already mentioned that I'm a palliative care clinician, that's kind of the lens I see things through. Palliative care is a discipline where we care for people with serious illness, and our focus is on improving quality of life for patients and families. I'm gonna skip that and say, so again, guided by what I've been seeing clinically, I really wanted to first understand what are some of the most important issues related to pain and opioid misuse, opioid use disorder, and people with serious illness. I knew, as I mentioned before, what I was seeing in people with HIV, and even though at that time I was practicing in an HIV care setting, managing opioid misuse and opioid use disorder, I had a lot of colleagues who were either oncologists or palliative care clinicians practicing in an oncology space, who would contact me and say, you know, we have all these patients who have survived their acute cancer, now they're a year out, and, you know, they are, you know, entering into survivorship, and they have pain, and they were previously on methadone for their opioid use disorder, and now they're being prescribed oxycodone and it's not going well. What do I do? So I knew that this was, you know, an issue. And so back in 2018, we set out to really try to characterize this issue more. And so we did a qualitative study of opioid management challenges in individuals with serious illness broadly. And so we used a national sample of palliative care clinicians that we got from advertising basically to the American Academy of Hospice and Palliative Medicine and the Nursing Society, the Hospice and Palliative Nurses Association. And we asked 7 open-ended questions about challenges faced when caring for patients with caring for patients being prescribed opioids and decision-making around opioid prescribing, and did a content analysis of this. So, so this was sort of an interesting like experiment in how to recruit people quickly. So we, as I said, this was a national sample, online sample, and it's but it was a qualitative study. So basically what we did was we recruited people and we gave them a pretty high incentive, around $100 an hour, to do this. We asked people to just type as much as they possibly would or could about the questions that we were asking them. And so we were actually able to get fairly rich data from doing this. And in fact, we opened the survey at like 2 p.m. on a Tuesday, and at 8 a.m. on a Wednesday, my research assistant called me and was like, I think we have to close it. We have 85 people. So that was a good lesson in terms of, you know, when you incentivize things, and it's a hot topic, you're going to get a lot of people really quickly, which was great. So we got 90% physicians, which is a bit unfortunate because this is a, in the real world, nurse practitioners in particular, and also physician's assistants, do a ton of ambulatory palliative care. So we didn't really capture that here. And we got, a decent proportion of academic and community folks. And so here's some of the themes that emerge from that. So care approach differences. So one participant said, cancer survivors who are free of disease, whose oncologist has been prescribing high-dose opioids for many years, only to decide this is not a good idea, then refer these patients to the palliative care clinic for quote unquote weaning, and the patients are not on board. So different members of the care team are thinking about this differently. And kind of along the same lines, but I just thought this was a cute quote. So sometimes they just go next door to the oncologist, who then gives them as many Percocets as they want. That's sort of more to the point. And then there are factors related to the disease itself or its treatment that impact decision-making. So when the patient has curative intensive therapy, I'm more conscious of the need to limit frequent escalations of medication due to future expectations to wean and stop opiate use in the future. So just to add some color to this, for example, especially for those who are, don't practice or don't practice in this area, we, for example, see patients with head and neck cancer where the intent is curative. And these are folks who enter into their cancer therapy often with a history of substance use disorders, because substance use disorders are associated with head and neck cancer itself. And then, if they are started on opioids and you don't think about weaning right when you start if you start their opioids and you don't think about it as a time limited thing, and you don't counsel people expectantly that, hey, this is something we're going to continue for as long as you need it, but we don't really think it's going to be forever. We think it's going to be during the course of your treatment, which we know is painful. Then it can be a lot harder on the other end to really, talk to people about, okay, now it's time to wean because you're doing better. And then a very important factor here is prognosis, right? So two alternative viewpoints here, though. So one is this idea that if the patient is likely to die, we are more lenient. If the patient is dying, we are the most lenient. So to me, that really reflects weighing risks and benefits. And, if somebody has a prognosis of, 3 weeks to be extreme, then their risk of developing an opioid-related harm is less, statistically speaking, than if they have a prognosis of, a year or 2 years or 3 years. So, so that's one way to think about it. But then there's also this other, not that these viewpoints, they don't oppose each other. They complement each other, I would say. That the risks, harms, and benefits don't go away or lessen if the patient has a poor prognosis. So maybe I might disagree with the lessen part, but they don't go away, right? So, you might have somebody at the very end of life who's working on life closure issues and wanting to, communicate that with family and friends. And that can be very difficult to do in the context of an active substance use disorder. So maybe, that doesn't necessarily mean that you would treat it, medically speaking, in the same way that you might treat it if they had, a multiple year prognosis, but you might still want to address it in some way with them and enable them to address it with people who are close to them. So in that context, we ask the next question, which is, what is the best approach to the management of opioid misuse or opioid use disorder in individuals with serious illness? So how do you actually manage these types of situations? So we again used a modified Delphi study, and we conducted 2 panels based on prognosis, because prognosis really did seem, based on our qualitative data and also the group of experts who put this study together, including myself, really felt that prognosis, the people were treating people very differently based on prognosis. So either weeks to months or months to years, and developed some common variations on a clinical scenario. So the base clinical scenario was a 50-year-old patient, with pain due to cancer or its treatment and unacceptable pain control. And the participants in this study were palliative care experts and addiction experts. And we also had people who had expertise in both areas. There aren't that many people like that around, but we tried to recruit as many of them as we possibly could. And then in the first round, we rated the appropriateness of various management strategies that we as the sort of study team came up with based on what we know to be sort of possible and relevant clinically. So we didn't have that same kind of brainstorming round that we had in the prior study, because we felt that we didn't really need it based on our expertise. And then an online review of the round 1 quantitative and qualitative results and discussion was the second round. And then we had people give their final ratings on these management strategies. So we had 129 experts who expressed interest, who we then invited to participate, and 120 of them participated in at least one round, and 70% of them completed all 3 rounds, which is, I'm sorry, 84% of them, 84% of them completed all 3 rounds, which is pretty good. Very good. And most of the experts were MD or DOs. Unfortunately, again, we have not done a great job of capturing nurse practitioners and physician's assistants. And these results were recently published in JAMA Network Open and JAMA Oncology. And I'll just kind of take you through, I just am very much in love with these infographics. So I try to show them whenever I can. I didn't create them. One of my wonderful staff created them, but here you see, so this is a patient who, this was the first paper we published where it's that base patient, and the patient comes into their cancer treatment already on long-term daily treatment with Suboxone, buprenorphine, naloxone, a treatment for opioid use disorder. So they already have opioid use disorder, it's already being treated. And we told people to assume they have excellent adherence to the buprenorphine, naloxone, to the Suboxone, and it's at the highest dose that you would want to prescribe. So those are not things that you would change. And so what people felt to be appropriate was to divide the Suboxone into 3 times a day dosing, which is something that, is, I would say, common in clinical practice anyway, but is something that if it's not being done, should be done right off the bat. And then after that point, if the pain control is still not acceptable, people felt that it was appropriate to discontinue the Suboxone and start methadone 3 times a day, which is absolutely fascinating. So this, if you think about it, right? So methadone is a treatment for both opioid use disorder and pain, right? If you're treating opioid use disorder with methadone, it is only allowed to be done in the context of a methadone clinic. It is illegal to do it in any other context. But if you're using methadone to treat pain, anybody with a DEA can do that. So, this, among other things, is just a very clear example of stigma, right? You can use the same drug for 2 different indications. One indication you can do in a regular old healthcare setting and anybody can do it, and the other one you have to do in a totally separate setting. But what we saw is that people were recommending this workaround. Just switch this person over to methadone. I think partially also because of a prevalent belief that is not supported by evidence, but is a prevalent belief that methadone is more efficacious for cancer pain than buprenorphine is. So again, that's not supported by evidence, but it's a pretty prevalent belief. And so people were just kind of taking matters into their own hands and switching people to methadone. And then people felt that continuing Suboxone and adding a full agonist was an appropriate thing to do if the person had a short prognosis, but uncertain if the person had a longer prognosis. And probably depends on, our qualitative work suggests it depends on lots of different factors, like how stable you think the person's opioid use disorder is, and, how much you really think that they'll benefit from the full agonist, et cetera. And then in terms of discontinuing the buprenorphine and starting a full agonist opioid, people felt that it was of uncertain appropriateness if the prognosis is shorter, but was not appropriate if the prognosis is longer. And no one thought that anybody should be referring these patients to a methadone clinic, which again, just really illustrates the fact that methadone's can be a really great tool. But, if you have somebody with cancer undergoing treatment, that's a full-time job. And then, methadone clinic is kind of a full-time job too. So, it's really a lot to ask of somebody to do that. So that was kind of what we're finding here. And then this other case that we published alongside the buprenorphine case was somebody who is coming from a methadone treatment program. And then they developed their advanced cancer. And they, in terms of their methadone, have good adherence, have been on a stable dose. So people felt that prescribing methadone, like taking, exactly the same as we found in this buprenorphine case, taking matters into your own hands as, the patient's clinician and just prescribing methadone 2 or 3 times a day, so that they don't have to go to the methadone clinic is appropriate. And then continuing the methadone daily at the methadone clinic, and adding another full agonist opioid was considered, I'm sorry, not necessarily at the methadone clinic, but just continuing methadone daily and adding another full agonist opioid was considered to be appropriate for people with a shorter prognosis and uncertain appropriate for people with longer prognosis. Asking the methadone clinic to split the dose was of uncertain appropriateness. And I think that mostly has to do with people's uncertainty about whether methadone clinics will do that. Some will and some won't. But people thought it was really inappropriate in general to discontinue methadone and start a full agonist, or discontinue methadone and start buprenorphine naloxone. So I think the other thing that these 2 cases illustrates is that continuing to treat the opioid use disorder is important. So nobody thought that you should just stop their opioid use disorder treatment and put them on oxycodone. Nobody really felt that was appropriate for anybody. There was always a way to try to continue to work in opioid use disorder treatment alongside of treatment of the patient's pain. Looking at the time here. I only have a few slides left, so I will go through this quickly. I want to leave a couple of minutes for questions. But just to say that this was another paper that we published with 3 other cases from that same study. One was somebody who had a recent history of opioid use disorder who is not on opioid use disorder treatment. Another one is somebody who doesn't have a history of opioid use disorder, but is being given traditional opioids for pain, and then has a urine that's negative for those opioids and reports repeatedly taking more opioids than prescribed. And then this last case of being prescribed traditional opioids for pain and then found to have urine drug screening repeatedly positive for benzodiazepines. And, as you can see, generally speaking, again, like there's a lot of reliance on prescribing buprenorphine naloxone, a lot of reliance on increased monitoring, a feeling that one should not be just tapering people's opioids, but rather kind of working with them. So I think the general conclusions from this study are that, experts favored not deprescribing opioid use disorder treatment, even at the end of life, even with people with shorter prognosis. And deprescribing opioids is an option, but often avoided if possible. This methadone issue is very complex and very intriguing, and something that we have lots of plans to continue to pursue. And then the next steps for this are to identify and operationalize implementation strategies for these various management approaches. And then in general, future directions for my program of research are to optimize opioid decision-making in people with serious illness, implement evidence-based practices for opioid misuse and opioid use disorder in people with serious illness. I mentioned briefly at the beginning that I have a whole line of work just about OUD and pain in primary care and opioid treatment settings, which is my NIH-funded research center, and then continuing to work on my cannabis stuff. And, as I said, there's a pending K-24 that I'm nervously crossing my fingers about. So I'm very committed to mentorship. It's mentoring the next generation of researchers in this space and continuing to collaborate with amazing people. And so these are just some of the people that I work with here and elsewhere. So that's it. I'm going to stop sharing so I can see folks. Sorry, I kind of went quickly over some of these things, but I wanted to make sure that we got to talk a little bit at the end. I'm just plugging my laptop in because I see that it's in its death throes here. Okay.
Thank you.
Great. Yeah.
Thanks so much. Really interesting. And boy, how complicated you know, the patients are that have this and management. We are open for questions. And if you have a question, as Dr. Chia mentioned earlier, please type it into either the chat or the Q&A, and I can monitor that. While we're waiting for people, since this is a Deprescribing research group, you know, in the past few years, we've learned some of the things that work, you know, to help people reduce their medication use if we think it might be inappropriate. Some of them are like direct to patient materials, like, you know, brochures mailed to home, and you know, there's other methods as well. And I was just wondering if you have some of those Deprescribing tools might be useful in these patients. And if you want, I can describe some other. You can pop this question if you want. But
no, that is so. I think that's a really interesting point in this group. So one thing that immediately makes me think of is, you know, I think there's a real interest in developing interventions for individuals at the beginning of their cancer treatment to help them understand that these are medications that are, you know, opioids are medications that are likely to be helpful to them, but are likely to be harmful to them in the very long term. And, you know, it can be hard to talk to somebody who's just about to start cancer treatment about the very long term when things are so uncertain. But at the same time, I think developing interventions to, you know, approach with patients at the beginning of their cancer treatment, how to view opioids and how to think about, you know, the ultimate tapering of opioids, you know, should things as expected get better, depending on the circumstances, I think is really important. And the other thing too, is to make sure people understand that opioids are not the only, I don't want to make it sound like, you know, the oncology treatment world and everybody related to it treats opioids as the only, but truly, I mean, opioids are really the centerpiece of pain management for these patients, and sometimes the rest of it kind of gets lost along the way. And so there are a lot of people who are very interested in developing behavioral interventions for pain during cancer treatment and things like that. So helping people understand that those are actually can be really important contributors to their pain management plan. Yeah, I mean, but for like the general primary care population, I think this idea of like going to patients directly, I mean, I think patients are really bombarded with anti-opioid messaging generally. I don't know if that's kind of what you had in mind. I mean, obviously it's not tailored in any way, but I mean, I think one of the challenges is that people are very much bombarded with non-tailored anti-opioid messaging. So like one of my mentees, Haley Bulls, is very interested in opioid stigma. So this idea of like, you know, particularly in patients with cancer who may very well need opioids during their treatment, opioids, because of the messaging that people get that opioids are so bad that they are, you know, afraid to even try an opioid, or limiting how much they're taking, even when maybe they shouldn't be, because of the messaging they're receiving. So it seems like tailored messaging would be better than mass messaging. Yeah.
that makes a lot of sense.
I don't know if that addresses what you were thinking.
Yeah. It does. See if there are any other questions.
I have a question. You know, one of the things that's intriguing about what you talked about, Dr. Merlin, is that, you know, there's all these specialists, right? There's the oncologist, primary care, there's palliative care, there's addiction. And one of the challenges in deprescribing clinical practice is sort of this care coordination, like who's going to be responsible for deprescribing. And you know, in general medicine, as you all know, it's a little bit less clear. Like there might be one specialist, or there might be 10. There might be the diabetologist and the cardiologist and the et cetera, and the primary care. And nobody really wants to step on each other's toes. And so I guess my question for you is, like, how do you decide, or what lessons are there from care coordination? Because it seems like in your world, at least, there's a little bit more clear responsibility, or maybe not, about who should take on the deprescribing or how to have that communication.
Oh gosh, yeah, what a complex question, right? Because there's also, I think maybe I'm wrong, but I feel like with opioids and benzos and a few other related things, there's very much this isn't this isn't something I want to deal with, so somebody else should. I mean, there are like chemotherapy. Nobody would think that a primary care clinician should prescribe chemotherapy, and everybody would think that an oncologist would, but, and then there's probably some things in the middle, but like this is one of these things that people are actively, like, nobody wants to really take responsibility for, especially in patients who don't clearly continue to be under the care of anybody other than a primary care clinician, right? Because like at a certain point, the palliative care clinicians may feel that this is, this is somebody in survivorship. This is not somebody who, and has chronic pain now that may be indistinguishable from low back pain from some other cause. Like, is this really somebody I should be continuing to take care of? They're not clearly the oncologist patient anymore. So that's all to say that, yeah, this is a really complicated issue. So one of my mentees and I, Devin Check down at Duke, and I are going to be resubmitting an R01 looking at this exact issue about care, like what is, especially for people with opioid use disorder and opioid misuse, how do we, who manages this and how, what are the right intervention? I mean, does this require something kind of separate? Some sort of separate intervention that coordinates with all. Ask these doctor if the pill is wrong. That's amazing. I love it. I can't wait to read that. But yeah, so right. So I think it's sort of an open question. I think it's a research question. Who should be responsible for this, and is it a particular specialty, or is it a new kind of entity that works within all the specialties, sort of like a medical home or something else like that kind of coordinates. So, and I think the answer to this question is very different for people with opioid use disorder and opioid misuse than it is for people who are just being prescribed opioids. And now there's the question of just deprescribing without this other stuff. And it's also probably pretty different for people who are at various stages of the cancer continuum. If it's active cancer, very different from like 10 years out. And then there's everything in between. So yeah.
No, thanks. I like that you articulate this as a research question. I think that's right.
Sorry,
nobody knows how to do this, right?
Great
so
research
that's
question. We're working on that. Yes, exactly. Yeah.
Thank you.
Yeah, thanks for that.
So there is a comment. It's just ask your doctor if this pill is wrong with you, which you already said. And was there somebody raising their hand? I saw a hand go up, but I wasn't sure. I missed who that might be. It kind of floated by.
Yes, it's me.
Oh, it's me. Okay. There you go. Okay.
Oh, that was you. You were raising your hand to say, ask your doctor if this pill is wrong for you.
You don't mention, and I was wondering, about pharmacists, in deprescribing, we work a lot with pharmacists, and I was just wondering, and it relates to the last question about care coordination, have you involved, to what extent have you engaged pharmacists, and, were they, what role you might see for them in this work? Yeah,
so what a great question. So, and I'm sure there are people on this call who could speak to this way more than I could, but because none of my work is at the VA, but because I do pain and opioid stuff, I have a lot of very close colleagues at the VA, and there's a very robust literature on a lot of this stuff within the VA. And so one thing that the VA has done is created these, they're called different things at different VAs, but the general name is like opioid reconsideration clinics. And oftentimes pharmacists play a really central role in those clinics. And so there's some good published examples of those. But, as you're sort of alluding to, I think in the general world, I think pharmacists are, unfortunately, often are not utilized to the full extent of their license. Like, they're clinicians who could be collaborating clinically, but the systems that we have set up often don't include them. And so unfortunately, yeah, so my work to date has not involved pharmacists, but I think you raise a really important question, especially in that K-24 implementation work of like, how might we involve pharmacists in some of this, and like, how might we involve pharmacists in the implementation of buprenorphine in a cancer center? I think that's a really good question. Yeah.
And sort of piggybacking on that, there's a question from a junior investigator who's a pharmacist who's wondering what the best way to get involved would be, who's a pharmacist.
Oh, let's see. I suppose one of the best way to get involved is get involved in this work, or get involved in say more. Oh, yes, in this work. I forgot they can't unmute themselves, I guess. Okay. Oh, please contact me. I think this would be great to talk about. I'm so excited. That's, one of the reasons I was particularly excited about coming to this group is I thought, oh, this will be great for talking about future collaborations. So yeah, I would love to, I'd love to talk more. So please, I will just real quick, I don't know if I can actually put my, hi, BB, that's great. Yeah, my email is merlinjs. For some reason, it doesn't seem like I can put it in there, but it's Merlin, J as in Jessica, S as in Sarah, at pitt.edu. So please email me. I'd love to talk more. It's a great thought.
Other questions? Any advice on running Delphi panels? We haven't really talked about that as a research method in this group. I mean, not focused on.
Okay.
And
yeah.
What kind of knowledge do you gain from them, what you've learned, and if people are considering using this method, what your advice would be.
Absolutely. So my email address, sorry, there's a request to repeat. It is Merlin, J as in Jessica, S as in Sarah, at pitt.edu. I'm pretty Googleable, so you can probably just Google me. My main advice about doing Delphis is to collaborate with Rand. So I did 2 Delphis, as I showed you, one where I didn't collaborate with Rand and the other where I did, and it was a direct function of money. So I had one I was funding off of, like my startup funds when I was junior faculty, and I had like almost no money. And then I had another one where I had the Cambia Health Foundation grant where I had, big chunk of money. And so the reason why is because, this is its own research technique and methodology. And now that I've done 2 of them, I'm sometimes called upon to be a Delphi methodologist on other people's work. But, so the pearls about Delphi are, they are not to get people to come to consensus on something. They are to determine whether consensus exists. And sometimes it can be just as interesting to understand if there is consensus on something as to whether there isn't. And oftentimes you find that, as we did in our studies, that the consensus is, I don't know, which is not the same as disagreement. People can agree that there's no good answer to this question. And then you rely a lot on the qualitative results to kind of give that additional nuance. And you can follow up on that with more Delphi work to try to capture that nuance. But I think it's very powerful. I think it's, when you're able to say that there's consensus level evidence that you should not I didn't show this data specifically, but that you should not taper people just because their urine is positive for cocaine, which is another arm of this Delphi study, who have cancer. There are whole programs that just taper people just when they find out that. So I think just being able to show them, like, look, this is not what people think you should do. It's bad, then I think it is really powerful, actually. So, and I think, the work that I like to do is the type of work where there's like, it's where the rubber hits the road and there's no good answer. And so generally that's where Delphi comes in handy. And so it's been very helpful for me in these areas where you're not going to do a randomized trial. There isn't that level. There's not going to be even high quality observational evidence. You're just going to have to find out what people are doing and then test how well that works.
Great. Well, we're at the top of the hour, wherever you are. And thank you so much, Dr. Merlin, for joining us, for teaching us about this topic, which I think is relevant, to the work that we're promoting in the US Deprescribing Research Network. And we will look forward to hearing more from you and your work in the future. Just as a matter of housekeeping, the recording for the webinar will be posted on the US Deprescribing Research Network website. You also will be, those who have attended will be emailed a short evaluation survey that we hope you will fill out. The other announcement is that we have another webinar coming up March 14th, and the topic will be engaging stakeholders into deprescribing research. So, and that will be at 2 p.m. Eastern on March 14th. So thank you again, everybody. Thank you to our presenter, Dr. Merlin, and to our attendees, and we look forward to seeing you again.
Thank you so much. This was really a pleasure. Thanks for having me.
Thank you.
All right. Take care, everybody.
Bye-bye.